I wrote an article in the BMJ in September of 2009. And I'd written the article in February or March of that year and revised it because it was a bitter, ranting article at the beginning because I was so upset at what happened. But I wanted to distill some key messages from the piece. So yes, having decided that I would send it to the BMJ, and I knew the BMJ would take it. I'd been in touch with them and said I wanted to do this, and they had seen a draft of it and said they would definitely take it. So I knew it was going in. And then I got Jocelyn Cornwall, who heads a study in compassion, effectively, the point of care study at the King's Fund, to write a commentary on it alongside my oncologist, which is how these articles are structured. There was no question of making a complaint. I mean, transactionally, I was dealt with brilliantly by my local hospital. And there was no hesitation about that. It was just the debacle about the subsequent unfolding of the story, of the narrative of my diagnosis, that was deeply disagreeable. The diagnosis was established very quickly after I'd had an X-ray, which had shown pleural effusion in my right lung. I'd had some symptoms, a cough, which I thought was a viral infection for about 8 weeks. But because it persisted, I asked my GP for an X-ray. And at that point, he set up very quickly an appointment with a respiratory physician, who in turn set up an appointment with a cardiothoracic surgeon for a biopsy. And really, the whole procedure from being referred to having the biopsy took place over about a week. And I think actually operationally couldn't have happened any more quickly. So technically things went very swiftly and very positively. But it was after I'd had the biopsy, which was, again, the anaesthetist was round and asked me was I okay, and the third surgeon came round and asked me was I okay after the biopsy. But what was interesting was that they all looked very, very despondent about their findings. Their findings were on a video-assisted thoracoscopy, so everyone could see my chest, which looked terrible, looking at the reports. And increasingly, I became aware of their despondency. So I got more frightened, really, as that period went on. And I remember the SHO coming into the room. He'd been an undergraduate student with me for a year or two. I knew him very well. I could tell he was very, very upset and wanted to talk to me about it. But I think he felt that he didn't have the authority to do that. I left hospital the next day, still without any clear understanding of what was happening to me, and came home to the kitchen in my house, where I opened the discharge summary, because I have access to my own records, obviously, and the discharge summary included the phrase, likely malignant mesothelioma, patient aware of diagnosis. So that's how I learned that I had a mesothelioma, reading it at the kitchen table. I think it's important to say at this stage that although that wasn't the right way to learn about it, I think everyone was trying to do the right thing. And the first I learned directly that I might have a mesothelioma was from the specialist cancer nurse who came in to show my wife how to drain the pleural catheter, which is in my right chest. And he, again acting very conscientiously, said to me and my wife, if I wanted any information about mesothelioma, he'd lots of it available. But there was a point where everyone in the team, including my wife, knew that I had a mesothelioma, and I didn't. And that can't be right. I think there may have been something in the fact that being a doctor, I'm being roughly the same age as these guys. I'm in my late 50s. Most of the consultants were in their late 50s or 50s, you know, and our kids would be the same age. This is completely curtained, this diagnosis, so you can see them thinking, God, this guy's out to it. And They just weren't. They weren't brave enough. They weren't brave enough to say, this is really bad news for you. Maybe that they hid behind the science of their biopsy and pathology to avoid confronting the metaphysics of my predicament. I am a man devoid of hope. And I just sensed that they hesitated at that point. And my own view is, sounds quite hard, is I just don't think that's good enough. Medicine is not solely a technical activity and pursuit. Medicine is about understanding and being with people at the edge of the human predicament. Caring for somebody is a transactional activity where they do things to me. Everything that I've had done to me in our local hospital has been excellent. There has been a single mistake. I'm seen it on time. For things transactionally, I think the place is outstanding. It's the relational care where I felt that the experience has been less than satisfactory. And it's been a mixture of some really shockingly bad interactions and some shockingly good interactions, some surprisingly good interactions. But again, I want to stress that when I perceive people to be interacting poorly with me, I still, and I mean this, I still think they're trying to do their best. I still think they don't think that they're actually upsetting me in a particular way, but they are. And my insight into the experience is it doesn't take much to change from upsetting or insensitive communication to communication that puts someone much more at their ease. I think that there are a number of sort of interactive bear traps that one can fall into. And one of the problems is actually quite a sophisticated problem, which is that the healthcare professional does a job. And for many people, this job is pretty mundane. They're doing the same kind of thing to the same kind of people pretty well every day. So for them, that activity becomes completely routine and on some days rather dull. For the individual, it's anything but that. It's anything but that. Every individual that comes through a hospital is apprehensive. It's a strange place. You lie in a strange bed that's very firm, you have strange sheets, you have odd tea in a plastic cup. The whole thing is vibrantly different. One of the examples that particularly seemed to upset me, and I'm not sure if this is just me being oversensitive, is people saying, do this for me, put your hands behind your back for me, turn your arm out for me, pop up on the bed for me, just tell me your date of birth for me. And I've mulled over whether this is just me being grumpy, which is possible, or whether there's something more important. And I would defend myself by saying I think it is important, because I think there's something about a locus of control in someone who says to you, do this for me. They are retaining control over that transaction. And I think that's a classic example of being cared for, that is being transactionally involved and not being cared about, where they don't know really who I am. They don't really care who I am. I think individual healthcare professionals inadvertently heap small humiliations repeatedly on patients, and they do it inadvertently. I'm mentioning this inadvertently. An example which got me early on in my days of having CAT scans was that I was told to undress, instructed to undress. The phrase that was used was, we need to get you to get your clothes off, down to your pants. And you're wearing pants and socks and shoes. That's a cool sartorial combination, which I have to say I don't indulge in very frequently myself, except when I'm having CAT scans. So you're with pants and socks and shoes, and this gown that you hope is fastening at the back and not exposing your bum to the radiology world. But I was sitting there with a green plastic bag holding my clothes, hoping that the back of my gown was closed, when a senior radiographer walked briskly into the patient's area and said, "Kieran Sweeney, follow I." And like a sheepdog, I just got up and followed this guy. Like, I don't know what's going to happen next, but but this crass attempt at humour, follow I, just humiliated me. I felt just utterly degraded. I felt seriously upset by it. That he should so trivialise what was for me a shocking passage into my healthcare problem. I'm so angry about that. And I think he was doing it inadvertently. I think he was trying to be, I don't know, he was trying to be witty or funny or something, but you just can't do that, or you've got to be awfully careful about doing that, really. Rediscovering the humanity in a patient, I think is a lovely phrase, and I think is an infinitely rewarding pursuit for healthcare professionals to pursue, to take an interest in. That's really why I came into medicine. It was to be with people at the edge of the human predicament, but to understand them when they were there, and to some extent to let them understand me being with them at that point, at the edge of the human predicament. Now, let's not beat about the bush here. That's what doctors do. That's our job, and it's a hard old job. And it does require technical competence, but well beyond that, the competence of the serious individual. I mean, society needs to understand that only serious people can be healthcare professionals, because it's a deadly serious job, really. And inside that job, if you're able to identify the humanity of the patient as well as provide them with technical competence, it's such a win-win situation. It's so rewarding for the patient to be treated sensitively and technically competently, and for the healthcare professional to feel that they have touched that patient in a way that has technically helped them, but also regarded them and understood them as an individual.